Most people on Medicare in 2026 are operating on information that is 2 or 3 years out of date. And in a program that changes its premiums, deductibles, coverage rules, and drug formularies every single year, 2 or 3 years is a very long time to be running on outdated assumptions. The rules changed. The costs changed. The traps that were always there became more expensive to fall into. And the prescription drug savings that seniors spent decades fighting for finally arrived. But only for specific medications and only if you know how to access them. What did not change is the fundamental misunderstanding that most Medicare beneficiaries carry about what the program covers, particularly when it comes to nursing home care, observation status in hospitals, international travel, and the coverage gaps that original Medicare has never addressed. Getting one of these wrong does not produce a minor inconvenience. It produces a bill for tens of thousands of dollars that arrives at exactly the moment you can least absorb it. This covers everything that matters about Medicare in 2026 across 5 areas, and it is organized to move from the changes you need to know about immediately to the planning decisions that protect you over the long term. First, the financial changes now in effect, including the prescription drug savings and the rising premiums. Second, the coverage gaps in original Medicare that will catch people off guard this year. Third, the nursing home trap that has destroyed retirement savings for millions of American families and how to avoid it. Fourth, what actually happens to your Medicare coverage when you travel outside the United States. And fifth, the tax and financial strategies that transform unavoidable Medicare out-of-pocket costs into meaningful deductions. Every section contains practical, specific, and immediately actionable information. Take notes and read through to the end, because the final section on tax strategy alone is worth the time investment for anyone who has faced significant out-of-pocket medical expenses in any given year. The most significant financial development in Medicare in 2026 is the arrival of negotiated prescription drug prices, and the numbers are more dramatic than most people expected. For the first time in the program's history, Medicare has been granted the legal authority to negotiate drug prices directly with pharmaceutical manufacturers on selected high-cost medications that do not have cheaper generic alternatives available. 10 drugs were chosen for this initial round of negotiations, covering treatments for some of the most common and costly conditions affecting older Americans, including diabetes, cancer, heart disease, and rheumatoid arthritis. The price reductions that resulted from these negotiations are substantial by any measure. The diabetes medication Jardiance, which had a list price of $527 per month in 2023, now carries a negotiated Medicare price of $113, a drop of 79%. Farxiga, another widely prescribed diabetes drug, fell 68% from $556 to $178 per month. Enbrel, a medication used for rheumatoid arthritis that previously cost over $7,000, has been negotiated down to approximately $2,300, a 67% reduction. Across the 10 drugs included in this first negotiation cycle, nearly 9 million Medicare enrollees are projected to save a combined $1.5 billion in out-of-pocket costs during 2026 alone. For someone who has been paying full price on any of these medications, the savings are immediate and do not require any action on the beneficiary's part beyond confirming their plan's updated formulary. These price reductions are the direct result of legislative changes that pharmaceutical companies spent enormous resources opposing, and they represent the most meaningful shift in how Medicare handles high-cost medications since the program's creation. Equally important is the out-of-pocket prescription drug spending cap, now in effect under Medicare Part D. In 2026, the maximum amount any Part D enrollee can be required to pay for prescription drugs in a single calendar year is $2,100. That figure was introduced at $2,000 in 2025 and adjusted upward by 5% to reflect inflation. Before this cap existed, Part D had no absolute ceiling on annual drug costs. The coverage gap, known as the donut hole, followed by a catastrophic phase in which seniors still owed a percentage of drug costs indefinitely, meant that beneficiaries with complex medication needs faced open-ended annual drug expenses with no guaranteed stopping point. People rationed medications. People skipped doses. People made the kind of choices between healthcare and basic living expenses that no one who paid into the system for 40 years should ever have to make. Once a beneficiary reaches $2,100 in out-of-pocket drug spending in 2026, their personal cost responsibility for the rest of the calendar year drops to zero regardless of the actual cost of their medications. Whether the drugs being dispensed are worth $5,000 or $50,000 to the plan, the beneficiary pays nothing further after hitting the cap. The $2,100 cap is not just a financial limit, it is a planning tool. Before this cap existed, a beneficiary managing multiple chronic conditions had no reliable way to know in January what their drug costs would be by December. That uncertainty made budgeting for retirement income genuinely difficult. The cap eliminates that uncertainty for anyone whose annual drug costs exceed the threshold. At the same time, the base costs of Medicare are rising, and those increases will offset some or all of the benefit improvements for many beneficiaries. The standard Medicare Part B premium in 2026 is $229 per month, an increase of nearly $18 from the prior year. Part B covers physician services, outpatient procedures, preventive care, and durable medical equipment. For the vast majority of Medicare recipients, this premium is automatically deducted from their Social Security payment before it is deposited. The maximum Part D deductible has risen to $615, meaning enrollees must pay that amount out of pocket before their prescription drug coverage activates. The practical consequence of these simultaneous increases is that the Social Security cost of living adjustment many beneficiaries received at the start of the year may be partially or entirely consumed by higher Medicare premiums before the money ever reaches their bank account. Budgeting for 2026 without accounting for these offsets leads to cash flow surprises that compound over the course of the year. Understanding where your coverage begins and ends in 2026 requires knowing not just what changed, but what has remained stubbornly unchanged for 6 decades. Original Medicare, meaning Parts A and B operating together without supplemental coverage, contains exclusions that have existed since the program was created in the 1960s and that continue to generate significant unplanned expenses for beneficiaries who assume their coverage is more comprehensive than it is. Routine dental care is not covered. Cleanings, fillings, root canals, extractions, dentures, and implants are entirely out of pocket under Original Medicare. Medicare Advantage plans sometimes offer dental coverage, but those benefits are typically capped at $1,500 to $2,000 annually. A single crown or a single implant frequently exhausts that entire cap, leaving the beneficiary fully responsible for any additional dental work in the same year. Routine vision examinations and prescription eyeglasses are not covered by Original Medicare. Hearing aids are not covered, despite extensive research demonstrating that untreated hearing loss is one of the strongest modifiable risk factors for cognitive decline in older adults. A pair of quality hearing aids can cost several $1,000s per ear, an expense that falls entirely on the beneficiary with no Medicare assistance. Adult incontinence products are classified by Medicare as personal hygiene items rather than medical necessities and receive no coverage. These are not occasional or unpredictable expenses for many aging adults. They are recurring monthly costs that accumulate into thousands of dollars annually that must come from somewhere in a retirement budget. The absence of dental, vision, and hearing coverage from Original Medicare is not medically defensible given what research shows about the connections between oral health and cardiovascular outcomes, between vision problems and fall risk, and between hearing loss and dementia. But the exclusions remain, and the planning burden falls entirely on the beneficiary. In 2026, a new 6-year pilot program took effect specifically in 6 states: Arizona, New Jersey, Ohio, Oklahoma, Texas, and Washington. This program introduces prior authorization requirements for certain medical devices and procedures under Original Medicare in those states. If you live in one of these states, a physician recommendation is no longer sufficient on its own to receive certain categories of treatment or equipment. Medicare approval must be obtained first, which introduces an administrative layer and potential waiting period between a clinical recommendation and actual care delivery. Being aware of this requirement before a medical situation arises means you can ask the right questions at the point of care rather than discovering the requirement after a procedure has been scheduled or performed. The area where the most financially devastating misunderstandings occur in Medicare involves nursing home care, and it is an area where the damage is often irreversible by the time it is discovered because the costs have already been incurred and the savings have already been depleted. The core of the misunderstanding is the failure to distinguish between skilled nursing care and custodial care. Skilled nursing care is short-term medically necessary treatment that requires licensed clinical personnel to deliver. Post-surgical rehabilitation, intravenous medication administration, complex wound management, and speech therapy following a neurological event are examples of skilled nursing care. It has a defined clinical purpose and a recovery endpoint. Medicare covers skilled nursing care under specific qualifying conditions. Custodial care is assistance with the activities of daily living, including bathing, dressing, eating, using the bathroom, and moving safely within a living space. It does not require clinical training to provide, and it is typically ongoing rather than time-limited. Medicare does not cover custodial care. It has never covered custodial care, and the 2026 benefit structure does not change that exclusion in any way. A senior who enters a nursing home because Alzheimer's disease, severe mobility limitations, or general physical decline has made independent living unsafe will not have that care covered by Medicare regardless of the medical severity of their underlying conditions, regardless of how many years they paid Medicare premiums, and regardless of how much financial hardship the cost creates. The average cost of nursing home care in the United States in 2026 is between $8,000 and $10,000 per month. That is between $96,000 and $120,000 per year, paid entirely out of pocket in the absence of Medicaid eligibility or a long-term care insurance policy. Accessing the skilled nursing coverage that Medicare does provide requires navigating a precise and unforgiving sequence of qualifying conditions. A beneficiary must have a formal inpatient hospital stay of at least 3 consecutive midnights. The day of discharge does not count toward those 3 nights. The beneficiary must enter a Medicare-certified skilled nursing facility within 30 days of hospital discharge. The care received at the facility must be skilled care explicitly ordered by a physician. If all conditions are satisfied, Medicare covers the first 20 days at full cost with no beneficiary coinsurance. From day 21 through day 100, a coinsurance of $217 per day applies. After day 100, Medicare pays nothing. It is also worth understanding that the coinsurance cost of $217 per day for days 21 through 100 represents a total potential exposure of $17,260 if a beneficiary stays the full 100 days. Families who have not reviewed their Medigap coverage in advance of a hospitalization frequently discover this cost structure for the first time when the skilled nursing facility sends its first billing statement. A Medicare supplement plan can cover some or all of this coinsurance depending on the plan type. A separate and particularly dangerous trap is observation status. A patient can spend multiple days physically present in a hospital, receiving physician visits, nursing care, diagnostic testing, and meals, while being classified administratively as an outpatient under observation rather than as a formally admitted inpatient. Days spent under observation status do not count toward the 3 midnight inpatient requirement. Any time a hospitalization occurs where subsequent rehabilitation care is a possibility, ask explicitly and get it in writing whether the patient has been formally admitted as an inpatient or is being held under observation status. Retirees who travel frequently, whether for extended periods or shorter trips, need to address the international coverage gap before they leave the country, not after a medical event has already occurred abroad. Medicare coverage stops at the United States border in nearly all circumstances. The 3 exceptions are narrow. Emergency care received while traveling through Canada on a direct route between Alaska and another U.S. state may be covered. Emergency care at a foreign hospital closer to the patient than the nearest U.S. hospital may be covered. Care on a cruise ship within 6 nautical hours of a U.S. port may be covered. In virtually every other international scenario, medical expenses are entirely out of pocket. A serious medical event abroad can generate costs in the hundreds of thousands of dollars with no Medicare coverage to offset them. Supplemental travel health insurance is not a discretionary extra. It is the only realistic financial protection available. One of the most overlooked financial tools available to Medicare beneficiaries is also one of the simplest in concept, even if it requires discipline and execution throughout the year. Managing the burden of uncovered Medicare expenses requires understanding one particularly valuable tax strategy. The IRS allows taxpayers who itemize deductions to deduct unreimbursed medical expenses that exceed 7.5% of their adjusted gross income. With an adjusted gross income of $50,000, the threshold is $3,750. Any qualified unreimbursed medical expenses above that amount are deductible in full. Medicare Part B and Part D premiums qualify. Out-of-pocket costs for dental care, hearing aids, and eyeglasses qualify. Hospital coinsurance payments qualify. Transportation to and from medical appointments qualifies. Nursing facility costs qualify when the primary reason for residence is medical care. In a year when a beneficiary faces significant medical costs, systematically tracking every qualifying expense and applying this deduction can substantially reduce federal income tax liability. The key discipline is maintaining organized and complete records of every qualifying medical expense throughout the year so that the full deductible amount can be captured accurately at tax time. The most important thing to take from this is that every item covered here is addressable in advance. None of these gaps, traps, or cost increases appear without warning. They are all part of a documented and publicly available benefit structure that rewards people who study it and penalizes people who assume they already know what it says. The financial landscape of Medicare in 2026 rewards beneficiaries who understand it and creates expensive surprises for those who operate on assumptions. The prescription drug savings are real. The cap provides genuine predictability. The premium increases must be factored in. The coverage gaps require supplemental coverage or dedicated savings. The nursing home distinction must be understood before it becomes relevant. The observation status question must be asked during every hospitalization. The international travel gap is manageable with supplemental insurance. And the medical expense deduction is available to every beneficiary who tracks their costs carefully. Every single one of these elements is within your control to understand and act on. This is USA Benefit Advisor.